All right, welcome. If you're studying for your PEDS exam, you know that pediatric emergencies can feel like one of the most stressful topics out there. So in this explainer, we're going to cut through the noise and break it all down into high-yield, need-to-know concepts. Let's get right into it.
So let's just jump into a scenario. Picture this. You're on call, a 4-year-old is rushed in, totally unresponsive after a fall. Your heart starts pounding, right? The whole team is looking at you. That first minute can feel like pure chaos. But the key isn't knowing everything all at once. It's about knowing exactly where to start.
And to bring order to that chaos, here's our game plan. We'll start with a foundational approach to any sick child. Then we'll dive into some high-yield specifics, trauma and burns, poisoning, and of course, shock. We'll wrap it all up with a rapid-fire list of the key things you need to remember for your exams. Sound good? Let's go. First things first, let's talk about the absolute bedrock of pediatric emergency medicine. Before you even think about a diagnosis, you need a solid framework that you can rely on for every single patient, every single time. It's your safety net. And that framework is, of course, the ABCD approach. Now, this is so much more than just some letters to memorize. It's a life-saving sequence of priorities. We always start with A for airway. Is it open and clear? Then B for breathing. Is the child actually breathing effectively? Then C for circulation. Are they perfusing? What do the pulses feel like? D is for disability, a quick check of their neurological status. And finally, E for exposure, so you can properly examine the child from head to toe. Getting this sequence down is hands down the most critical skill in managing any seriously ill kid. Okay, so we've got our foundational ABCDEs down. Now, let's apply it to a really high-yield topic, trauma, specifically burns. Managing burns in kids is all about precision, especially when it comes to getting their fluids right. The very first step with any significant burn is to figure out the total body surface area, or TBSA, that's been affected. And this isn't just for documentation. This percentage is the critical number that will dictate your entire fluid resuscitation plan. Getting this calculation right is absolutely vital. So, how do we do it? Now, you've probably heard of the rule of nines for adults. For kids, forget it. It's not accurate. Instead, we have to use the Lund and Browder chart, which you see here. Just look at how the percentages for the head and the legs change depending on the child's age. It's brilliant, really. It accounts for the fact that kids have proportionally larger heads. This is the tool you need to use for an accurate TBSA in children. Once you get your TBSA percentage from the Lund-Browder chart, you plug it straight into the Parkland formula. As you see here, it's 4 ml of fluid, usually Ringer's lactate, times the child's weight in kilos, times that TBSA percentage. But here's the crucial part, the part they always ask about on exams, the timing. You give half of that total amount in the first 8 hours from the time of the burn, not from when they arrive. The other half is given over the next 16 hours. You gotta know this one.
All right, let's switch gears and tackle pediatric poisoning. This can feel pretty overwhelming, right? There are so many potential toxins, but the key to not getting lost is all about pattern recognition.
And that's where toxidromes save the day. A toxidrome, as this table shows, is basically a cluster of signs and symptoms that points you toward a specific class of poison. So instead of trying to guess one specific drug out of thousands, you look for a pattern. Is it cholinergic, anticholinergic, opioid? Recognizing the toxidrome is a massive clinical shortcut that gets you to the right treatment fast.
Let's focus on a super high-yield example, the cholinergic crisis. This is the one you see with organophosphate poisoning, from pesticides. And the classic mnemonic for the muscarinic signs is dumbbells. That's diarrhea, urination, meiosis, those pinpoint pupils, bronchospasm or bradycardia, emesis, lacrimation, and salivation. You see that pattern? You should be thinking cholinergic crisis.
So you've got it, you see the dumbbell signs, you've diagnosed a cholinergic crisis. The next question is critical. What do you do right now? What are the specific, life-saving antidotes you need to give this child? And here's your answer. We just look at our table of common antidotes, find organophosphates, and there it is. It's a 2-drug combo. Atropine, which fights off all those dumbbell symptoms, and pralidoxime, which actually gets to the root of the problem and reactivates the cholinesterase enzyme. You need both, and they are absolutely life-saving. Another incredibly common one you'll be tested on is paracetamol or acetaminophen poisoning. For this, we have a very specific tool, the Rumack-Matthew nomogram. Here's how it works. You have to get a blood sample at least 4 hours after the kid took the pills. Then you plot that paracetamol level against the time since they took it. If that point lands above the treatment line on this graph, you have to give the antidote,
N-acetylcysteine, or NAC. This is what prevents that devastating liver damage.
All right, on to our last big topic, mastering pediatric shock. This is one of the most time-critical emergencies we deal with. Early recognition and a really aggressive, systematic response make all the difference between a good outcome and a bad one. So what exactly is shock? Well, the textbook definition is a state where the circulatory system just can't provide enough oxygen and nutrients to meet the body's needs. Basically, it's a massive failure of perfusion at the cellular level, and that's what leads to organ damage.
Now, shock isn't just one thing. We have to classify it to treat it properly. As you can see in the table, the main types in kids are hypovolemic, from losing fluid, like with bad diarrhea; cardiogenic, which is pump failure; distributive, where the blood vessels get superdilated, like in anaphylaxis; and septic shock, which is often a messy combination of a few types. But here's the thing. While the causes are different, the very first step in management for most types of shock is fluids. And there is one single number that you absolutely have to burn into your brain. And that number is 20 milliliters per kilogram. That's your standard opening move, a 20 milliliters per kilogram bolus of an isotonic crystalloid, like normal saline. It is non-negotiable and incredibly high yield.
Let's look at how this plays out in septic shock. This management algorithm is basically your playbook. You see, it all starts with that 20 ml per kg bolus we just talked about, and you give it fast. If the child is still in shock, you can give another bolus, and you start getting your vasopressors ready. Things like epinephrine or norepinephrine to help support their blood pressure. The key is this stepwise, rapid escalation of care.
Whew, okay, we have covered a lot. Now for what might be the most important part for your revision. Let's condense everything we've talked about into a quick, final checklist for your exams.
Ready? Here are your must-knows. Number 1, always start with the ABCDE approach. For pediatric burns, use the Lund-Browder chart and calculate fluids with the Parkland formula. For poisoning, recognize your toxidromes, especially dumbbells, and know your key antidotes, atropine for organophosphates and NAC for paracetamol. For a child in shock, your initial fluid bolus is 20 ml per kilogram. And finally, always be thinking about the reversible causes of cardiac arrest, your 5 H's and 5 T's. That's your cheat sheet.
So, the whole point is this. Managing pediatric emergencies isn't about memorizing 1,000 rare diseases. It's about going from chaos to control. And your tools to do that are a systematic approach, pattern recognition, and knowing a few key numbers and formulas cold.
At the end of the day, it all comes back to the basics. The number one goal, as our sources tell us, is to provide adequate breathing and circulatory support, and to keep assessing that neurologic status. If you're doing that, you're on the right track.
So, you've got the framework now. You have the fundamental tools. The real question isn't just about what you know for the exam, but how you're going to apply this structured thinking the next time you're faced with a real, critically ill child, because that is what truly makes all the difference.